Hello, welcome to my channel. This is Dr. Emmanuel. This is a video on tips that could help one pass the DRCOG, that's the Diploma of the Royal College of Obstetrics and Gynecology exam. So I did my DRCOG in April 2022, and I just think there are a few tips that could be really helpful for anyone who is intending taking this examination. So looking at the structure of the DRCOG, it's actually just an exam-based, program. So it's not really a program that entails you, doing a course over 6 months or 1 year. So you just prepare for your examination, take the examination, and when you pass, you are awarded the diploma certificates, okay? Just like many other, degrees like the MRCP, MRCS, they are majorly exam-based qualifications. So the DRCOG is a 3-hour examination within which you'll be needed to answer 120 single best SBA questions, so single best answers. Previously, I think some months or some years ago, there used to be extended matching questions, the EMQs in the DRCOG, but this is no longer, part of the DRCOG. So you have 120 single best answer questions in 3 hours. So usually in the DRCOG, time is never a problem. As long as you're moving at a reasonable pace, you would finish, because you have enough time. I think the exam used to be once a year, but I think they've now created a second slot, so usually twice a year. And if you follow this website, you can get so many information. Just Google, DRCOG and go through the RCOG website. You'll get information on the dates that are available, the cost of the exam, and some other guides, some frequently asked questions regarding the DRCOG. This is extracted from the RCOG website. So I extracted this from the RCOG website. These are the models or the aspects or areas, the areas you'll be tested on. So essentially, there are 7 models, as we can see. So, the individual seeking fertility regulation and sexual health assessments, coupled with sub-fertility. So there were questions, on fertility. There were questions on early pregnancy. Questions on pregnancy, like second trimester, third trimester. There were questions on labor, management of labor, decisions you need to take. There were questions on peripartum, the peripartum or the perinatal, phase, both for the woman and her baby. There will be some questions on emergency gynecology and on emergency obstetrics. And then, non-urgent gynecological problems. So you get questions in all these domains or models. And one thing about this DRCOG exam is that it's a very technical exam. I think in recent times, I've taken, within the last 2 years, I've taken about 7 or 8 exams. And I will say this DRCOG was among the most technical exam. So it's a very applied exam. And to be honest, if you pass this exam, you will feel happy because it then means that you've actually got a good understanding, a good grasp of what clinical, application of obs and gynae knowledge is like. When you pass, this is what your certificate will look like. So you can see the Royal College of Obstetrics and Gynecology, and your name will be there. The signature of the president of the college will be there, and the dates you took your exam will all be there. And then that's the logo of the Royal College of Obs and Gynae. This is a book. So this particular book here, written by Susan Ward, the DRCOG revision guide. I got this book on Amazon. It wasn't so expensive. I can't remember how much exactly now, but it was within a reasonable price, about between 20 to 30 pounds, I think. And this book was so helpful. In fact, it was as though the exam was a replication of this book, to be honest. That's how I felt. And that's why I said anyone who who asks me about the DRCOG question, examination, I'll always recommend that they get this book. So this is the second edition. There's a third edition. So this second edition, which I bought, contained both the single best answer pattern and the extended matching questions, which I found both helpful. But I think the third edition is now tailored to the new pattern of the exam, which is purely SBA questions, okay, single best answers. Other resources that you could find helpful are Pass Medicine. So you could subscribe to Pass Medicine, the DRCOG part of it. You could also subscribe to the BMJ 1 examination or on examination. And then you could search Telegram. Usually Telegram contains a lot of materials on any exam you're preparing for, be it DRCOG, PLAB, MSRA, MRCP, whatever it is, USMLE. There are loads of resources on Telegram, so that's a useful guide. We've got the NHS leaflets on, on several conditions. So this NHS leaflet and even the RCOG leaflets are so helpful. For instance, when you look at the management of management of labor, in a HIV positive patient, and how the CD4 count, plays a role in this in affecting your decision making. Whether you're going to apply instrumental delivery, forceps, ventures, whether you're going to book the patient for elective or emergency cesarean section. So reading leaflets, so you can just go on your Google and type in management of labor in HIV positive pregnancy patients, NHS or UK, and then read what the guideline says. So you might not necessarily read the entire guideline, but you can use the leaflets, which are actually shorter forms of the guidelines, and then you can read the leaflets. Very important. Know what the common conditions, what the leaflet says. So I've written down a few things I think should be very helpful before you sit this examination. Try to find, try to read about these and read around all of these that I've listed. So the first one is the management of, asthma in pregnancy. So you need to know what the guidelines say, in terms of how you manage both the acute exacerbation of asthma, and, the chronic asthma management in pregnancy, okay? So you could be asked questions like, Montelukast, aminophylline, steroids. They could just ask you, five options on Montelukast. So you need to know whether Montelukast is first of all indicated or contraindicated in pregnancy, same as aminophylline and prednisolone. So you need to know what the guideline says as regards the various asthma medications in pregnancy, in different trimesters of pregnancy. Another thing you need to know is the DMARDs, the disease-modifying anti-rheumatoid drugs, all these DMARDs and some other autoimmune, other immune-modifying medications, things like the aminosalicylic, salicylates, mesalazine, and all of that, methotrexate. You need to know what the guideline says. Using methotrexate in pregnancy, is it contraindicated? Is it indicated? What adjustments do you need to take? What precautions do you need to take? So you need to know what the guidelines say on the use of DMARDs in pregnancy. For instance, if a patient who has ulcerative colitis or Crohn's disease, becomes pregnant, and she's on, let's say she's on sulfasalazine, what do you have to do then? Do you have to stop sulfasalazine? Do you have to switch her to another medication? Do you have to reduce the dose of sulfasalazine? So what do you do, in that situation? You need to know what the answer is. So check the guidelines. Management of ectopic pregnancy. I think this is very common. In my particular exam, there were so many questions on ectopic pregnancy, and at some point I was like, oh, is this an ectopic pregnancy exam? And it was very applied. So you need to know, how ectopic pregnancy is managed. Okay, the indications for conservative management, medical management, surgical management, and then pain, they could tell you patient is having dull ache. So does dull ache qualify as pain in the management of ectopic pregnancy? What's the size of the gestational sac? What's the level of the serum beta HCG? And of course, it was the patient's hemodynamic, status. So check the guideline. When can you safely, do conservative management, which essentially is watchful waiting, where you're monitoring, doing serial beta HCGs, seeing if the beta HCG is dropping or rising, also reviewing the patient's symptoms, or medical management where you can use, the parenteral methotrexate, or surgical management, which could be, either a laparoscopic salpingectomy or an open salpingectomy. So these are things you need to, read around. The next thing you need to know very well before a CT exam is the antibiotic regimens for treating pelvic inflammatory disease. Okay, you need to know what the antibiotic recommendation is in the UK. I will said HIV and instrumental delivery, and then NIPE, the newborn infant physical examination. So in pediatrics, neonatal pediatrics. So things like breech, how does breech presentation affect what the pediatricians will do, especially in terms of, hip assessment. So things like, if you look at the UK NIPE, the NHS NIPE guideline, you see that any baby who is born breech has to have an ultrasound of their hips. Okay, even if their examinations, the examination you do, the Otolani and Barlow's test, which you do, the maneuvers you do at birth to assess for congenital hip dysplasia, even if those examinations are normal or reassuring, the child still needs to have ultrasound of both hips. Now, if that examination is normal, then of course the child can have the ultrasound within 6 weeks. But if the examination is abnormal, then the child should have the ultrasound of the hips within 2 weeks, so earlier. So you should know what the guidelines are as regards, performing hip ultrasound in newborns who are born breech. Another thing is antibiotic treatment of UTI in pregnancy. So based on trimester, of course, in the first trimester, you don't want to use trimethoprim because it's antifolate. And in the first trimester, folic acid is so important for, organogenesis, okay? Organogenesis and even neurulation, formation of the spine. So neurulation, especially formation of the spinal cord and the spinal canal. So if you use trimethoprim, the child is likely at risk of neural tube defects, okay, spinal bifida and cranium bifida. So you can not use trimethoprim first trimester, but you can use it in second and third trimester. And you can use nitrofurantoin in your first and second trimester, but nitrofurantoin generally is avoided in the third trimester because of the risk of neonatal hemolysis. So you have to know exactly, I think it's about 24 weeks. You don't use it beyond, I'm not sure, I use 24, 26 weeks, if it's 24, 26 weeks, or probably 32 weeks, but just confirm the gestational age beyond which you can't use trimethoprim, okay? To confirm some of those things. Then know about the modern baby units. Not every hospital has this, specially designed unit, modern baby units. And the reason you need to know about this is mental health, management. So if a woman has peripartum psychosis, they could frame the question in two ways. If she's having evil or dangerous thoughts towards the baby, thoughts of having her baby, obviously you need to separate the mother and the baby. But later, if she's having psychotic symptoms, but she has no delusions, or thoughts, negative thoughts towards the baby, then it's safe to keep both of them together in the modern baby unit. So they could tell you things like maybe you need to, admit the mother into the general adult psychiatric ward or something. So if you think the baby is safe, The answer usually is to keep both of them in the mother and baby units. So you need to know about those things. And then diagnostic criteria for gestational diabetes, what value of fasting blood glucose, what value of random blood glucose, what value of OGTT. Do you diagnose gestational diabetes? I think the code is 5678. So fasting blood sugar above fasting blood sugar, I think it's 678. Fasting blood sugar above 5.6, and then random above 7.8, so 5678. I think that's the code, but you need to confirm that so I don't give you wrong information. Well, that's what's coming to my mind anyway. So confirm the diagnostic values of these various, indices for gestational diabetes. And then, you need to know organs that are likely to be damaged in laparoscopy. So if they tell you a patient is going to have a laparoscopic hysterectomy or laparoscopic salpingo-oophorectomy, they could ask you what organ is most likely to be damaged. And usually it's the bowels, because if you've assisted in a laparoscopy before, you see that the moment you introduce your pots, your instruments, you find out that your bowels are everywhere. Okay, the colon is everywhere. So bowels are usually the most likely structural organs to be damaged or injured in laparoscopic surgeries. Then you need to know about the diagnosis and management of miscarriages. Okay, threatened miscarriage, incomplete miscarriage, missed miscarriage. You need to know how you make those diagnoses based on what's happening. If the woman is having PV bleeding, if she's having abdominal pain or cramps, and if her cervix is closed, or if her cervix is open, or if you can see some fetal or blood clots in the os of the cervix. So you need to, and then of course your ultrasound findings also. You have a closed cervix, you have a non-viable fetus, that becomes a missed miscarriage. Okay, and you need to know how those are managed. Classification of the female genital mutilation, FGM. So you need to know how FGM is classified. Okay. Very important. Know it very well, because sometimes they could confuse you in the classification of FGM, female genital mutilation. So you need to know that. I think the type 1 is just, when the clitoris or the hood, is mutilated, So just know that. Another thing is know the classification of perineal tears. So if a woman is in labor and she sustained a perineal tear, you need to know the classification of that perineal tear. And then hormone replacement therapy. So you need to know how to apply the knowledge of prescribing HRT to women who are either perimenopausal or women who are postmenopausal. And you need to also know how having a uterus or not having a uterus, affects this decision. So for instance, what I'm trying to say is, are you going to give estrogen only HRT? Are you going to give combined estrogen progesterone HRT? If a woman has undergone a hysterectomy and has no uterus, you can safely give her estrogen only, because the estrogen you're giving her is not going to increase the risk of her having endometrial cancer, because she no longer has a uterus. But if it's a woman who still has a uterus, if you give her only estrogen, she's going to be at increased risk of having endometrial cancer. So you have to give her progesterone to reduce that risk. So you now give her a combined HRT. You need to know about the management of endometriosis. Of course, first line is usually analgesics, analgesia. And if it's not working, then laparoscopic surgery, okay, is done. And they could ask you a question, they could tell you a question, maybe a patient who has severe endometriosis everywhere, peritoneal endometriosis on the abdominal surface of the diaphragm, probably have adenomyosis. You've done a hysterectomy, you've removed the uterus, and then this woman probably done a bilateral salpingo-oophorectomy, okay, and maybe a hysterectomy, for instance, for severe endometriosis, but then you've now put her into menopause, and she needs hormone replacement therapy. So what form of hormone replacement therapy would you give this woman? She doesn't have a uterus anymore. Will you give her estrogen only? I think the answer is combined, because the progesterone you would give also helps with the remaining endometriosis tissues on the, that are left behind. But confirm that information. But I think that's what the answer is. You give a combined one. The other thing you need to be aware of is cyproterone acetate versus cyproterone acetate plus ethinyl estradiol, which is the cocyprinidiol. So cocyprinidiol is a combined hormonal contraceptive that contains cyproterone acetate as this progesterone component, whereas cyproterone acetate alone is just a progestogen without having an estrogen. Okay, and for people with polycystic ovary who have hirsutism, if you're a patient with hirsutism and polycystic ovary, and she wants a contraceptive, it makes sense to give her cocyprinidiol, because the cocyprinidiol would have the benefits of, probably regulating her periods more, and also reducing the severity of her hirsutism. So cyproterone alone is not usually used for that purpose. I think cyproterone alone can be used in men, for the treatment of prostate cancer. So don't get confused when you see cyproterone acetate as one option, and in the same question you're seeing cocyprinidiol, and you're like, oh, which one should I choose? And at that point, you might make a mistake. So try to find out the answers to all of these, okay? And try to get this book. For that, there are different materials, but if you can, try to get the 3rd edition of this book to really be helpful. This is extracted from the DRCOG website, just a sample question. Okay, so this is just a sample question. A 26-year-old nulliparous woman who has come with undifferentiated vulval intraepithelial neoplasia, and they're asking what the best treatment option would be. And they said, is it 5-fluorouracil cream? No. Laser destruction of the VIN? No. Local excision? Yes. The answer is no. Vulvectomy. They had said, oh, she has vulval cancer, probably a locally extensive, or you have been thinking of vulvectomy, but this is a local excision of VIN. So also check VIN for vulval cancer, cervical cancer, endometrial cancer. Read about them in the NHS leaflet and the DRCOG leaflet. Find out exactly what the management options are. Okay. So I think we've come to the end of these guides or tips, on how to pass the DRCOG examination. I wish you all the best in your examination. And if you think this video has been really helpful, kindly like, subscribe, share, and click on the notification bell so you'll be informed when I produce other videos. Thank you very much.